A warm welcome to you all to yet another exciting webinar brought to you by BlueKonnect. This session is proudly brought to you by Falcon iLab. My name is MMO-Squared. I am the administrator for the platform. A million thank you for taking time in your schedule to come and attend this webinar in the wake of what we are facing today as a country. As this is a webinar which depends largely on connectivity, please expect some delays in transmission, so the voice might be ahead of the video or vice versa. We sincerely apologize as that happens. It's largely due to connectivity. Secondly, please be advised that the platform did not allow us to collect your HPCSA registration numbers, so you'll shortly be requested to submit the same to us so that we can allocate points and send you a certificate. To ensure attendance, we'll be asking questions throughout the sessions to ensure that everyone is still paying attention. We request everyone to respond to the questions when they come, my apologies, so that we can ensure you are still there. Otherwise, we'll not be able to allocate points to those who did not answer. I've been repeating who BlueKonnect is all about, so I think for the purpose of this particular session, I will take it that some of you do know. If you don't, I am willing to share with you via email a brief about BlueKonnect. Allow me to introduce Nashua Naicker, who's going to be taking us through this exciting session this afternoon on Strabismus. For those of you who do not know, Nashua will introduce himself to you, and he will tell you where he's from, lest I misrepresent him. Mr. Naicker, the opportunity now is yours.
Okay, thank you, Mr. Kobe. Colleagues, thank you for your attendance. I'm Nashua Naicker. I'm an optometrist in Bloemfontein. I've been working at National Hospital, actually Universitas Annex, that's what we call. I've been there for 15 years. It sounds like a long time to be in Bloemfontein. My Afrikaans is still quite bad. I've been at the optometry department, and I've worked at the Binocular Vision Clinic, which is an academic clinic, so that's where we train the students. Okay, so I hope to keep you very engaged in this presentation. I've been given 2 hours by Mr. Kobe. I could speak for 10 hours, but I think everyone would need to sleep at some point, but not during my presentation. I really don't want you to develop some type of strabismus during my talk, so let me try and keep this very engaging. Okay, the aim and focus of this session, it's to guide optometrists to develop a systematic flow. Okay, because the reason is we come across many strabismic patients in our practice, and sometimes I think we're not really sure. We have the idea of all the tests that need to be done, so this is mostly a refresher for most of you, but I think it's important to have some type of flow, so your assessment with the patient moves much faster and you get to examine and diagnose much quicker as opposed to doing tests randomly. So it will help us very much to diagnose different cases much quicker if there was a protocol or a systematic flow that we had. So for today, the focus will be on constant, alternating, and intermittent strabismus in patients. And the age range I chose for this presentation is those that are school-going, early school-going, up to maybe those that are in the mid-20s who've maybe done with university or joining the labor force. I chose not to talk too much about pediatrics because pediatrics will take us into a different direction where we'll focus a lot on how we'll modify tests, how we change the way we communicate. So if I can say that's a different ball game, so we'll just I'll try to ring fence as much as I can on what we're going to focus on for today. Okay, so for the first hour, we're going to talk about how to conduct a thorough history taking, and I will zoom directly into maybe about 9 questions that I've listed, which I thought are actually quite relevant to ask a strabismic patient. We look at patient observations and the value of assessing their facial features. We'll talk about the motor evaluation of a strabismus. We look at the preliminary techniques that are indicated, techniques that are contraindicated, and how can we take certain techniques and modify it specifically in strabismic patients. This is before we begin our refraction. So in the next hour, we'll talk about how we'll do our retinoscopy and our subjective refraction, how we will do it slightly differently, and how we can alter the patient's prescription and why should we adjust the patient's refraction when dealing with strabismic cases. And finally, we'll end up talking about the sensory evaluation, which is our suppression testing. We'll talk about accommodation testing as well as stereopsis. So I've chosen a few tests which I thought were necessary. You could do more than this, but I'm just going to focus on these specific ones. So let's get straight into it. Okay, specific questions that will give you direction in your patient examination. So we're going to start off with getting what's the patient perspective. Okay, so very important, it's always in the beginning to really gauge how the patient reacts and how they feel about having a strabismus. So it's very important to ask the patient, very clearly, very assertively, are they aware they have a squint, or one eye is squint, or do they know if both eyes are squint? So you get an impression of how the patient feels about it. I've often seen some are quite reserved about it, were not very forthcoming, so they did feel uncomfortable, and that was specifically those teenagers, those in the adolescent age category. I think at that age, you're very conscious about physical appearance. Anything that's less than ideal, you're a bit sensitive about it. So it's very important in the beginning to get that impression of your patient that's in your chair. Okay, the next question I thought is important is, does the parent or the patient know when the strabismus was first noticed or occurred? Okay, the reason we need to know this is we're trying to see what is the etiology of the strabismus. Was there some trauma during childhood? Was it some systemic disease or neurological conditions that have created the strabismus? It will give us some idea about the risk of amblyopia. And specifically, if the parent says no, maybe the strabismus started after the first year of life or maybe in the second year, it kind of gives us an idea maybe what type of tropia we're dealing with. Like accommodative tropias don't really start within the first 6 months or within the first year of life. They often start much later in life when your accommodative system is well developed. Okay, the next question is it just one eye or the other eye or that turns in or out? Okay, so now we're trying to probe laterality. Is this a constant tropia? Is it alternating? So this is what we'd like to get from the patient before we examine them. Again, amblyopia is always something to think about in the back of our minds. So if it's an alternating, we know the risk of amblyopia is very reduced to actually being no risk at all. If it's constant, then we know the risk for amblyopia is quite high. All right, next question. Do you see double at times? Now, specifically for this presentation, we're focusing on patients that are asymptomatic, okay? Because there's been a lot of talk about strabismus and double vision and diplopia, but in reality, that isn't really common. Most of our patients are well adapted. They walk around with the strabismus, they're not complaining, they're comfortable, so which is why it's important for us to talk about those asymptomatic patients as opposed to those that are symptomatic. The next question, is the eye turn always there or sometimes only? So what are we probing here? Here we want to know, is this tropia intermittent, meaning are there periods where the patient does have binocularity, or is the tropia always there? Okay, so intermittent, again, it can tell you two things, that the vision could be very good, maybe there's no risk of amblyopia, or the patient could have very poor vision in the eye that deviates. And that will take us to our follow-up question. Okay, does the eye deviate when the patient is looking far, near, or closer, or when reading? Now that's quite important, especially for this age category we're talking about, where near vision is quite important, reading, and through this digital age that we are at this point, we're using a lot of digital devices. Our world has gotten much closer. So we really want to know what is the status of their binocularity. So that's the reason for asking that question. So if a patient says they notice their eye turning in, or maybe the parent will say that they notice the child's eye turning in when they're looking far, okay, or when they're looking at near. So we know this is what we call a periodic intermittent strabismus, because it's predictable. So we know, okay, when the patient is looking at distance, that's where the problem is. Okay. So the next question, did the patient have any eye operations? Okay. We're asking about this question because patients who had a traumatic cataract or a congenital cataract, it often leaves the patient with amblyopia, and in most cases it is something we call a sensory exotropia. When you start losing vision in your one eye, for example, you could have had a cataract in that one eye that wasn't removed for many years. The eye develops a type of exotropia more than an esotropia. So it drifts into that passive position or physiological position, which is more exo. And then that would leave the patient more exotropic. So asking that question will give you some idea whether the patient had some type of cataract previously, which you may not be seeing now. The next question, did the patient have any eye operations to straighten their eye, and at what age? Okay, so if the patient in your chair has a strabismus, and they do say they've been for strabismic surgery, so now you know the strab that you're seeing was, if I can say, tampered with. Maybe it had a larger angle and now it's reduced because you're still seeing it. We also want to know how many operations did they have, because it could tell you how successful the operation was. Okay. The reason we ask this question as well is when you're doing the cover test and examining the patient, very often you notice that the eye moves very strangely after the patient has gone for strabismic surgery. It has, sometimes I've seen a very geometric movement, a zigzag type of movement, very unusual to take up fixation. Then you know there was some adjustment done to the muscle, so the eye doesn't rotate very well. So if you know that the patient had surgery, then you'll understand why the eye is moving quite strangely than the way it should. Okay. Sometimes sometimes the patient gives you conflicting histories. For example, a parent would say, if you ask the parent, okay, how did the eyes look before they went for surgery? Because that also tells you, was there a problem that happened? Because if you're seeing the patient has an exotropia in your chair and the parent says, no, the eyes were turned in. So you keep that at the back of your mind, not to say the parent is wrong, but there is that possibility that there was an overcorrection that could have happened during the surgery. So now the patient who was esotropic ended up with an exotropia, which we call our consecutive strabismus. Other times parents will say both eyes were turned in. Now that's not very accurate, that it's just how they've seen their child's eyes. You can't have both eyes turned in or both eyes turned out. One of the eyes will be the fixating eye. Okay. And then the last question I thought was important is, was any therapy or patching done previously? The reason we should ask this is, while you're examining the patient, you may find that there's a large esotropia, okay? So and it's constant in specifically maybe the right eye. So you're expecting the amblyopia to have set in quite deeply. The visual acuity should have been reduced. But when you take the VAs, the best corrected VA, you may get about 6.75, and the better fixating eye is about 6.6. So you're seeing there's only a one-line difference, and that's not making sense. With such a large strabismus, you expect more lines to be reduced. The amblyopia should be deeper. But then if the patient said they had therapy previously, then you will join the dots and realize, okay, there was amblyopia therapy, so that's why the VA has improved so much now. And therefore you'll realize why it now makes sense that the patient who has such a large strabismus, but they still have good VA in that eye. Okay, so that would be just the main questions regarding the strabismus that we should ask, and we'll come back to some of the questions and some of the different scenarios you will encounter. So that's just the gist of what you should probe regarding your patient. So I've just made a list here of the flow diagram just to have a look at. The first part would be your pre-testing. Okay, so you'll cover the case history, your patient observation. You'll observe the patient's eyes while you're speaking to them. From the history, you'll develop something called a problem list, or you'll profile the patient. You'll extract valuable information that they reported to you, and you just put a list together. So as you work now, you start doing your examination. There's no need to go back to the history. You look at what you've listed or what you've extracted from the history. And you should at least have preliminary diagnoses or a tentative diagnosis from the history, which is then when you conduct your examination, you can either rule out or prove that your preliminary diagnosis was correct. And thereafter, you'll continue with your clinical assessment. You'll move to your preliminary evaluation. You'll do your relevant preliminary tests, which we'll talk about most of them. We'll talk about then your refraction, your objective refraction and your subjective refraction, and what we can alter and do different from there. We'll then move on to assess the accommodative system, which I think often is forgotten, that patients with the strabismus, they also accommodate as well, and we need to investigate that. And lastly, we'll do a sensory evaluation of the strabismus, because lots of patients, for example, if they don't have diplopia, you know they developed some type of sensory adaptation, and we need to investigate that. So this would be more or less our big categories for our evaluation. Okay, facial features. So when the patient is speaking to you, when you're working with the patient, it's very important to observe their face, look at the symmetry between the eyes, look at the eyelids, see what you can find that looks quite different, unusual from what is normal. For example, I found a nice picture from Wikipedia here, which shows it clearly. It looks like the patient has an esotropia in both eyes. But as you look, you can see that the patient has distinct epicanthal folds that are creating the impression that the patient has an esotropia. So if you look at the picture on your left, you will see the optometrist is pulling the skin at the bridge closer together, and in this patient you can see the eyes look aligned. All right, so sometimes you get facial features that can be very misleading to you, where you assume that the patient is tropic in your chair and they really don't have a tropia. In the internet, I struggled to find a photo of a patient that could have a pseudo exotropia. So there is no real tropia. Again, we call that pseudotropia. But in this case, I've experienced this. I've seen a patient that had an exotropia, or actually looked like they had an exotropia. So wherever I moved in the room, it looked like the patient is looking at me. So I would go from one end and then I'll go to the other, and then I see it looks like the patient is staring at me, or have their eye or their one eye on me. So if ever you experience that, you know that's just the patient's facial features that is creating the impression that they have an exotropia. So it would have been nice if I could find a photo of that. So let's look at facial features that conceal a tropia. okay, which is actually good to have cosmetically for the patient. All right, so if a patient has an exotropia, it would be good if they had epicanthal folds, because then it will hide the tropia a bit more, okay, because epicanthal folds make a patient look like they have an esotropia. So if they had an exo, it will be much better. A wider, flatter nose bridge helps for somebody with an exotropia, having a smaller PD. And just to recall the case I just spoke about, this patient of mine had a very large PD, greater than 70, and it created the impression that she did have an exotropia. And also a broader face. It will also hide an exotropia. So if you look at what can conceal an esotropia, would be not having epicanthal folds, okay, because that would just make it worse, or make it look worse. Having a narrow nose bridge is good, a larger PD for somebody with an esotropia, as well as having a narrow face. Okay. And this also brings me to something interesting. I had an optometry student many years ago who had an esotropia, and it was only in his final year that we discovered that he had a tropia, because his facial features hid the tropia quite well. So that was good for him. All right, so we've done our case history, we observed the patient, so now we're going to put together our problem list and extract that information. So let's quickly look at the list. This is just an example that I have here. So you list the exotropia, all right, so that's what you saw on observation. Patient awareness, so the patient was aware that they have this exotropia, and maybe they're comfortable with knowing that they have it. 2 years of age, it started when they were 2 years, and in brackets you can just indicate what's the patient's age now. OD only, meaning that it was only the right eye that's exotropic, and you'll say amblyopia risk. Okay, so we'll have to investigate that as you go on. If the tropia is intermittent, or the parent said no, sometimes they notice the eye swinging out, it's not always there. So then you need to rule out the presence of amblyopia, because it wouldn't be present in an intermittent tropic patient. Asymptomatic, the patient never complained of any visual disturbance. Manifests mostly when looking away. So, okay, so this is something important to list, because it's going to kind of lead you to a preliminary diagnosis. So you just need to say where the tropia manifested, when the patient reads a lot or when they're looking far. And you list there no surgery and no therapy. Okay, so there's no need to go back to the history. You have your list, and now you can move forward. And the tentative diagnosis that I came up with was a divergence excess exotropia, which means that only when the patient is looking far did the eye swing out. Okay. All right, so let's move on to our clinical examination. Our pre-refraction assessment. Okay. All right, OD and OS only. Okay, if the strabismus is obvious, okay, let me just see here. All right, if the strabismus was obvious, there's no need to do a binocular assessment on a binocular visual acuity, because you're expecting the patient to have suppression, because in the history they didn't report that they're experiencing any visual symptoms, any discomfort, any diplopia. So we're assuming at this point, it's just an assumption, the patient has suppression. But if you didn't know that the patient had a strabismus, for example, the facial features hid it. So at this point, then you will realize, okay, you would want to do a binocular VA, right? And later you find, okay, the patient, you do the cover test and you realize, no, the patient does have a strabismus. It doesn't matter. It's not a crisis, okay? So you can just disregard that binocular VA, okay? All right. The next test we will talk about is the cover test, but first let's start off with visual acuity. Okay, so you'll do your distance visual acuity. You will do your near visual acuity, no binocular acuity if the tropia is constant and or alternating. All right. Remember, at this point, you don't know whether it's constant or alternating. You're just going with what was reported and what you observed. Okay. Pinhole, I normally don't do the pinhole at this point because I am going to refract the patient. If I find that I couldn't get the patient's V8 to be as good as the fixating eye, then I would put my pinhole over my refraction to see if it can be improved any further, or if that was the best visual acuity that I could get, which means that an element of amblyopia had set in. Okay, so if the patient has binocularity, then you can do your distance visual acuity and you can check your near VAs. And also very important to look at the patient when you're doing binocular testing, because at times the eye could swing in and you may not notice that if you're looking at the chart or you're looking onto a screen. So it's also important to observe that in the patient. Your +2 test, okay, that's something not done very often, but it does have some value. Doing a +2 test monocularly on your patient, because we want to rule out whether they have latent hyperopia, or if the patient is esotropic. Okay, so we don't do the +2 test binocularly. Whenever there's a tropia, we'll do it monocularly. And you also want to know if this esotropia is accommodative or not, because it would work the same way as a latent hyperope. The patient will give you good visual acuities through a +2 lens. Okay. All right. Next, I'll talk about the static assessment. Okay, your static assessment, that is your cover test. So now we're assessing the strabismus where we don't need to get the patient to look in different directions. Okay, so we'll do this at distance and near. So I think often I'm asked the question as well, should we do it at distance and at near? And I notice sometimes when I work with my students, it's forgotten sometimes to do it at both distances. It really helps you come closer to a diagnosis, because you want to know whether the tropia, the size of the tropia changes from distance to near. Okay, it kind of leads you towards a diagnosis, or actually where the problem could be. Could it be more at near, or could it be worse at distance? So the cover test has to be done at both distances. Okay, and then you'll have to measure, all right, as opposed to just assuming, okay, it looks more bigger at distance than at near, so you would use your prism bar. Now, if you're not used to measuring a tropia or using your prism bar, it's understandable that you will forget that with an esotropia, we'll neutralize or measure the angle of the deviation with base out, and with an exotropia, we'll measure with base in. Okay, so how do you remember that? Okay, think of a prism as a triangle or as an arrowhead. I often say that. So the arrowhead points to where the eye is. So if a patient has an exotropia, okay, the arrow will point to the tropia. It'll point outwards. So you'll have the prism bar with your base in and your apex pointing out. If it's an esotropia, all right, so then you'll place your prism bar base out, where the arrow is now pointing inward towards the nose. So it's just a quicker way to remember how to use your prism to neutralize the deviation. Okay, so we'll do two types of cover test, the unilateral cover test and the alternating cover test, and I'll tell you why we do the alternating cover test. I highlighted the monocular binocular movement test, or the monoc-binoc test. You won't find this in any textbook. I just put this here so it's easy to remember how to do the cover test. So the unilateral cover test, you occlude one eye and you remove it. So it's monocular and then the patient's binocular again. Whereas the alternating cover test is the monoc-monoc test. So the patient is always using one eye at a time. So you move the occluder from the right eye to the left eye and back to the right eye. So why would we do the alternating cover test with a patient with a tropia? Because that's how we would measure. Okay, you'll detect a tropia by doing the unilateral cover test, but you will measure or neutralize it by doing the alternate cover test with the prism bar. Okay. Now we often say that if you do the unilateral cover test, you won't pick up aphoria. Okay, that's often what we tell students, but I can tell you that you can pick up aphoria when you do the unilateral cover test. So just as you cover, for example, if you cover the patient's right eye and you remove the cover, if you suddenly see movement in that right eye that you covered, you know that when you do the cover, the alternating cover test, you are going to see pick up aphoria. So one cover test can tell you whether a patient will have a tropia and aphoria. Okay, so here's something I added, just a clinical pearl. So we will be talking about things from my experience that I can share with you that hopefully that can help you along this presentation. How to elicit a movement of a very large angle tropic eye. Now, what I've noticed is patients with a very large esotropia. Okay, when you do the cover test, let's say the patient has a very large esotropia in the right eye. When you cover the left eye, sometimes the right eye doesn't move out to take up fixation. It's so large that the eye somehow becomes lazy. It just gets stuck. Now, don't be confused and think, okay, the patient has now a muscle palsy. That's why the muscle can't contract to turn the eye outward. So what I do is I use a sort of a auditory stimulus. I would click my finger, or I would give an instruction. I will say, can you see the chart? Are you looking at the target? So I would use some sort of auditory stimuli to trigger the patient to use some sort of mental effort to take up fixation. And that works very well to speak while you're doing the cover test. Okay, now we move to our dynamic assessment, because now we're expecting the patient to move their eyes. Okay, so let's ask ourselves, why do we need to do these tests? Pursuits. Okay, the reason we do it is we want to know if there is synchronization of movement. Are both eyes, is the fixating eye and the tropic eye moving by the same amount to the left and to the right, up and down? We just want to know if both eyes are moving together by the same amount. The reason is you can pick up some sort of oculomotor syndromes that you wouldn't see if you didn't do pursuits, like Duane's retraction syndrome. Had you not done pursuits, you wouldn't pick this up. Or Brown syndrome that you get in children. Without moving the eyes, you actually miss a lot of syndromes and a lot of inconcomitant deviations, which is caused mostly by muscle palsies. So if the person has good pursuit movements, we say that the neurological function is intact, because your pursuit control, your pursuit eye movement systems is controlled by brain areas in your parietal lobe. Okay, so if the movement is fine, we're happy, we move on to saccades. Saccades is very important for this age category we're talking about. Reading is very important because that you make saccadic movements when you read and not pursuit movements. Okay, because you need to jump to the words very quickly. All right, so it's a fast eye movement system. So why we test this? We just want to know if the eye is able to make a fast jump and stop. Okay, we call it our phasic and tonic actions. So if that works well, again, we know there is the neurologic function is intact, which is mostly mediated by your frontal lobe and your frontal eye fields and your brain stem as well. Okay, our last test in terms of eye movement will be Ductions. So when we look at Ductions, it's your pursuits. You're just doing it monocularly. So you're doing it occluding your fixating eye, and you get the patient to move the strabismic eye in all positions of gaze. If the eye can move in all directions everywhere, we know that there is no muscle problem. Okay, because we often forget that strabismus is not a muscle problem. Okay, it's a communication problem between the brain and the extraocular muscles. So if the eye can move everywhere, we know there's no restrictions, there's no mechanical restrictions, and there's no muscle paresis. So we can't actually say that this strabismus is due to a muscle problem, even though sometimes it's just easier in lay terms to say that to the patient, and I often do that as well, because it's just simpler to say that the eye muscle sometimes is not working too well. NPC. Okay, this is something interesting. We ask ourselves, should we do an NPC in a patient with a strabismus? Okay, so I'm not sure. What do you think? Do you think we should do an NPC? Okay. Most of the time, we shouldn't do an NPC if the patient has a constant or an alternating tropia. Okay, so why? Because fusion is needed, okay, to assess the patient's convergence. Okay, and the reason we assess the convergence, once again, it's quite important for the near binocular vision, okay, especially if you're in school and your work requires you to use a lot of digital devices. So if the patient has an intermittent tropia where the patient has binocularity at near, I will want to assess the patient's NPC at this point. So then we ask, okay, what targets should we use? Should we use an accommodative target when we do NPC? Should we use a non-accommodative target? I often found it's more reliable or more natural to use an accommodative target, because what happens in real life? When we converge, we accommodate as well. Okay, so why not stimulate accommodation while the patient is converging? Unless you find that there's a problem that makes you want to now differentiate, is this an accommodative issue or is this a vergence issue? That's when you will do NPC using an accommodative target and a non-accommodative target, which can be your pen light and maybe a red lens in front of one eye. So just to take you quickly back to a case that I've seen where I've used a non-accommodative target and the patient, converged nicely. And then I've decided to use an accommodative target when I did NPC. As soon as I directed the patient's attention to the accommodative target, the eye swung in and the patient became tropic. So fusion broke. And I was quite surprised because I didn't see this before. I did the NPC fine with the light. And then I used the light again, and the patient had good binocularity. So I realized as soon as the patient attempted to accommodate, the eye swung in, which means fusion broke. And later this revealed that the patient had an accommodative esotropia, okay, which wasn't picked up earlier. All right, so this is more what I would call your convergence excess type of esotropia, where the convergence is so great that it pulls your eye in more than what your reserves can compensate for. So fusion just broke at that point. So that's the reason I would actually prefer to do NPC using an accommodative target. Some may ask, should we do NPC with the patient's glasses on, the habitual correction, or without the glasses on? I would prefer to do the NPC without the patient's prescription, because I want to know what is the patient's state of divergence before I use lenses or use the patient's prescription that is going to interfere or change the result. Okay, and later we're going to talk about repeating some prelims that need to be repeated in a strabismic patient. Confrontation testing. So I'm not going to talk about pupil reflexes because, well, that's compulsory, that you do in every patient. But confrontation is our last prelim technique before I pause and look at a few questions that you may have. Confrontation testing is important for assessing the patient's binocular visual field. We normally don't do that. we assess the patient's monocular visual field. We close one eye and we check the field in that eye, and then we close the other eye and we check the field in each eye on its own, right? But why not assess the patient's binocular field? Okay, because that's quite important. So how do you treat? So I listed 3 questions there that we should actually ask ourselves. Firstly, why is confrontation testing additionally done binocularly in a strabismic patient? And in aligned eyes, there is overlap of your nasal visual fields to compensate for the blind spot in each eye. So in a patient with an exotropia, will a more temporal blind spot manifest with a much larger suppression scotoma than with an esotropia? Okay, and the last question, do you consider a strabismic patient a monocular patient when assessing visual field testing for driving? Okay, for example, strabismic patients can drive a car. Okay, so how do we actually treat them? Do we assume that they have no field from that eye that is strabismic because they're suppressing? But we didn't really measure the size of the suppression scotoma, so how do we know they have no field at all? Okay, so that's actually quite interesting, because I would like to do a binocular field test in a patient that is strabismic. So let's look at this exotropia that I'm talking about, right? So here's the eye that's deviated, okay? So now the blind spot shifts quite temporally to the point where your fixating eye won't compensate for that blind spot. So that blind spot will now be present in the strabismic eye and in the fixating eye. So a patient with an exotropia may have blind spots that are there, and your suppression scotoma extends from your blind spot all the way to your fixation area. Research says it's in the shape of a D. Okay, so I'm not sure how they work that out, but they say your suppression stretches from your fixation point, from your fovea, and it bulges outward towards your blind spot. Okay, so what I would find interesting is maybe there is a machine out there, maybe I should research, I'm not sure, but most automated visual field machines assess your monocular visual field, because you want to pick up visual field defects from pathology. But I would like for there to be a binocular visual field machine just to pick up the size of your suppression scotoma, or to see how much of field does the patient have? Do they have peripheral fusion with maybe central suppression in that eye? We're not really sure. Okay, so to bring you to the bottom point that I state there, that the size of the deviation and your suppression scotoma varies with different patients. So it just depends on the angle of the strabismus. Okay, it will tell you how large the suppression scotoma is. So I would want to test a patient's binocular field, especially if they intend to drive. Some ophthalmologists advocate referring patients for strabismic surgery. In these cases, they say not just for cosmetic correction, but you saving some of the visual field. All right, so that's also controversial. Possibly if you straighten the patient's eye, then the suppression scotoma may become smaller, because now the patient will be bifoveally fixating. But straightening a patient eye gives that patient really ocular alignment, but it doesn't really align the brain. That's the issue. That's the issue, because suppression is a sensory adaptation. It's a sensory anomaly that happens in your brain, not in your eye. So by straightening the eye, we may not be fully eliminating the suppression scotoma. Okay, so let's see if there's any questions that if I can help answering. Let me just have a look here. All right, I can't see any questions that I can specifically run through very quickly, but let's see here. All right, so I'm going to proceed. So we will take questions towards the end, so we don't delay. All right, let's talk about your refraction. Okay, your refraction, and how do we do things slightly different? Okay, no drastic changes. It's just that when we're doing retinoscopy, we will do retinoscopy occluding one eye. Why do we do that? Why do we need to occlude an eye? Because sometimes we tend to miscorrect or incorrectly refract a patient, especially because of the error of parallax. So the eye would be turned in or turned out, so it's not directed straight ahead. So to just sort that problem out, I think it's best that we just occlude one eye and refract the patient that way. Okay. Again, if it's an intermittent tropia, you don't need to occlude the eye, but then again, you're not sure when fusion is going to break while you're doing retinoscopy, so it's best to just occlude each eye at a time when you're doing retinoscopy. All right. I think that's it about retinoscopy regarding a strabismic patient. Let's talk about the subjective refraction. Okay. Let me see here. All right, so would we do binocular balancing in a patient with a strabismus? Okay, again, I've highlighted constant or alternating tropias. Binocular balancing is not indicated, okay? Because if the patient is suppressing one eye, then you're not doing a binocular refraction, so it's actually contraindicated. If the patient has an intermittent tropia and they have binocularity, then yes, you can proceed to do binocular balancing. Okay. So the next bullet, okay, if the patient has an intermittent tropia that's unpredictable meaning it's non-periodic, you're not sure when the strabismus is going to manifest during your assessment. Okay, so at this point, then you can attempt to do binocular balancing, but it's always important to watch the patient's eye if they suddenly break fusion, okay, because you are fogging one eye, you are causing some sort of disruption to the patient's binocularity, so you may induce the tropia or you may force it to manifest, and then the technique falls apart. Okay, so you can't really balance the accommodative effort between the eyes. Okay. If your patient has, also a strabismus, if it manifests at near, okay, and not at distance, then again, you cannot do the binocular balancing because now the patient is tropic at near, all right? So when the patient is tropic at near and you're getting them to look at distance, when the eyes, let's take an example. Let's say the patient is esotropic at distance. Okay, and now you start to fog the eye. Okay, let's say it's an intermittent tropia. The patient is esotropic at distance. Once you start fogging the good eye, what's going to happen? The patient's esotropic eye is going to take up fixation. Okay, but what's happening then behind the fog? Okay, the eye moves into its passive position of rest. So now the fixating eye moves in. So the technique falls apart then at that point. Okay, so the last bullet, if it's a type of strabismus that only manifests at distance, then you don't need to do the balancing technique. All right, so that's your subjective refraction. There's not much about it regarding a patient with strabismus, but now we come to something really important, that what needs to be done before we talk about a cycloplegic refraction is you have to repeat some of the prelims, okay, after you've refracted your patient. You want to know, with your refraction in place, did you now induce a problem? Did you make a problem worse, or did your refraction actually help the patient in their binocularity, in achieving better binocularity? Okay, For example, what test you will ask me that you should do. I would repeat my NPC. I would want to know, in this patient with an intermittent strabismus, with my refraction in place, did I now cause the NPC to get worse? Did I cause the patient to fusion to break down more often? Or would my refraction actually help the patient's NPC get better? Another test that I would like to do is I would like to remeasure the tropia. I would want to know if my refraction altered the deviation. Hopefully, I would like to see that my refraction has helped minimize or the angle or reduce the strabismus angle. I think those two tests I would think is actually important to repeat after you've done your refraction. There's no need to do any other prelims after you refracted your patient. Okay, so let's talk about a cycloplegic refraction. Why do we need to paralyze the accommodative system when we're refracting a patient? What would tell us that we need to do that? So the answer is, if I suspect that the accommodative system is masking the true refractive error, okay, or if it is driving the fusional system to break down and manifest with the tropia. So there's two reasons why I would want to do a cycloplegic refraction. So then I put a follow-up question, which then becomes obvious. So why? What about the examination that will make you think that accommodation is influencing the strabismus? Okay, it's good enough to suspect, but we have to be practical. The patient is in the chair. What is causing us to suspect that accommodation is playing a role here in the strabismus that is present? So here's a list of answers, right? The patient has an esotropia that's coupled with hyperopia. The intermittent esotropia that's manifesting more at near than at distance. So in these cases, I'm thinking, okay, it's accommodative, right? We're going to talk about the two types of accommodative, which is why I spoke about the hyperopia. And the second bullet is talking about the tropia manifesting more at near. The third answer would be, I noticed that my patient has an intermittent esotropia that alternates between the eyes when fusion breaks. Okay, so fusion breaks down and it's alternating, and it's very rare to find a patient that has an intermittent tropia that eventually becomes alternating. Most of the time you see a patient who has an intermittent tropia where there was no intervention for many years, and as time goes by, it starts to become constant, unfortunately, but in a specific eye. It's not quite often you will see an intermittent tropia that becomes alternating, jumping between each eye. So then you suspect something is causing that pull, that fusion to break. Okay, so the last one is obvious, your case history, very important. What did you get from the beginning? When you spoke to the patient or when you spoke to the caregiver, what did the parent or the person taking care of your patient said about the esotropia? Did it start later in life? The average age is about 4 years old, and sometimes they say, research says that a child can have a esotropia that manifests up to 6 years of age. And it's an accommodative esotropia, which is very rare for a strab to start so late. So if it has to start that late, you need to start to think about an accommodative tropia, where the non-accommodative esotropia, the most common is your infantile, that happens within the first year of life. It's really a large esotropia, more than what you would neutralize with your prism bar, which is 45 prism diopters. Okay, so I've listed here, I just described an esotropia to you, just not to deviate too much from being practical, because our patient is still sitting in the chair. So he can wait while I'm talking to you. So let's talk about accommodative tropia quickly. All right, let me quickly see if there's any questions about atropia for now. I'm just going to run through your chat to see if anyone had any questions.
Yeah, there were a couple of questions.
Okay, all right. Then if I can get some questions, I'll answer it at this point.
Okay, I've noted them for you. The first one was saying, is it fair to provide driver's license certificate for someone with code 10 if they have a strabismus?
Okay. For a strabismus, I think that depends on what is the requirement for code 10, all right, versus your code 8. Are you going to treat this esotropic patient as a monocular patient? I wouldn't treat them as a monocular patient because I don't know what is the extent of the patient's visual field. For a monocular patient, yes, it's quite obvious. I'm only testing the visual field in the one eye. Whereas with a strabismic patient, maybe he has a small angle tropia. Maybe he has a peripheral fusion, so he may have a bit more of a visual field peripherally than he would centrally in one eye if he has a scotoma. So it varies. I would test the patient before I decide whether to say yes or no.
Okay. The second question says, if a child has refractive amblyopia in one eye and strabismic amblyopia in the other, how should binocular balancing be approached?
Okay, that's an interesting one. All right, so the patient is amblyopic. One eye has a high refractive error, so I guess we're talking about it's an anisometropic case, and the other eye has the strab. Okay, so if the strab is constant, if it's always there, we cannot do binocular balancing because the patient has no binocularity, right? So let's park that aside and let's just say now the patient only has refractive amblyopia. Okay, so let us say this refractive amblyopia, maybe they -6 in one eye and maybe a -0.50 in the other eye. If there's more than 2 line difference between the best corrected visual acuity, I cannot do binocular balancing because the patient will start to be more monocular now. All right, so there's criteria for when you can do binocular balancing and how many line difference you should get between the eyes to do binocular balancing. Okay, so again, just to recap, if it's an esotropic patient with amblyopia, if it's a constant esotropia, then the patient has no binocularity. I cannot do binocular balancing. If the patient has a refractive amblyopia, I would look to see what is the best corrected VA in the poorer eye and how many line difference between the good eye and the poorer eye to determine whether my binocular balancing procedure will be successful or not.
Okay, I have 2 more questions and a follow-up on the first one. So let me start with a follow-up.
Okay.
The follow-up on the first one, which was asking about driver's license, saying
Yes.
that each eye has to have a 6/9 visual acuity for code 10. So what is the likelihood that your strab patient is going to have 6/9 in the deviating eye?
Okay, now let's talk about which strab case you're talking about now. All right, if the patient has an alternating strab, in most cases they don't have amblyopia because amblyopia didn't set in because there was no competitive advantage between the eyes. As soon as there's a competitive advantage where a patient fixates more with one eye than the other eye, that's when amblyopia will start to set in. Okay, so if it's a constant tropia, I would expect this patient to have amblyopia, okay, in that one eye. If it's alternating, there won't be any amblyopia. But besides acuity, I think we must also consider visual fields as well as part of that criteria. So I won't only go on acuities. I think I will consider visual fields and acuities together in deciding on issuing the driver's license permit.
Okay, the second last question for now, it says, is it recommended that one should perform cycloplegic refraction on patient of any age as long as they have some sort of tropia?
Okay, first I will look at what is making me consider doing a cycloplegic refraction. All right, it's true, you don't need to do a cycloplegic refraction on any esotropic patient that walks through the door. Right, I won't do a cycloplegic refraction if it's an exotropia, because I know accommodation is not involved, is not driving that eye to be exotropic. Accommodation will always influence the eye to be esotropic. So I would look at what factors now with this patient in my chair that is wanting me to do a cycloplegic refraction. Okay, so just like the previous slide showed, what is happening, what is it about that case? If the patient is hyperopic with an esotropia, I would think maybe that the accommodative system is trying to mask that hyperopia, like with the latent hyperope, and it's causing the patient to accommodate at distance. And by over-accommodating at distance, it's pulling the eye to turn in. So that would be one factor I will consider. If the patient has no refractive error, or if he's myopic, I would be reluctant to do a cycloplegic refraction. Then the next point is I'll look at the patient's binocularity at near. Does his eye turn in at near more than at distance? If it does, then I would want to do a cycloplegic refraction. If that's not the case, I wouldn't. So there's different factors that will lead you to consider doing the cycloplegic refraction or not, and it would be those factors. Thank you.
Okay, then the last question I had on that session was, why and how does a high refractive error, hyperopia in this instance, induce a strap in pediatrics patient?
Okay, I think that's the slide that you're seeing right now. So I think my slide will now answer that question for you.
Okay, there was one more follow-up on that driver's license. I don't know if you want me to... Okay.
All right. Let's talk about the driver's license.
Okay. It says, my question about the driver's license certificate for code, I assume it says code 10, is assuming that monocular VA is 6.9 or better. But what about binocular vision? Does this not play a part for driver's license of heavy motor vehicles?
Binocular visual, are we talking about the patient having a strabismus?
Yeah, I think that's basically.
All right.
Yeah.
If the patient has a strabismus, okay, and is not symptomatic of diplopia, I know he has single vision and he's going to have suppression. All right. So the fact that the patient is having suppression, then I know that I'm only going to focus on his monocular VA. So yes, he's driving with, let's say, his both eyes open, right? Like he's supposed to. But the visual acuity of the strabismic eye is not relevant at that point. So that is why with an, for example, an exotrope or an esotropic patient, whether he has a tropia that's alternating or constant, he's always using one eye at a time. So your monocular VA will be valuable more than your binocular VA at this point, because again, if he has suppression, you can't have a binocular VA, if I'm making sense, if I'm answering your question.
Okay, I think I will note this next batch of questions, then you can proceed in the meantime.
Okay, all right, thank you. Okay, this accommodative esotropia. Okay, what is it? All right, there's different types of accommodative esotropias. There's one type that is due to high hyperopia, and I put in brackets uncorrected. Okay, it's uncorrected hyperopia that will give you an esotropia, because once you correct the patient's hyperopic refractive error, the hyperopia, the esotropia will disappear. Okay, and just very quickly to deviate just for a minute, something I should have mentioned in the beginning during case history. When your patient comes in with spectacles, it's always nice to ask them to remove their spectacles while they're talking to you. Because if they had an esotropia, an accommodative esotropia that's fully corrected, you fully correct the hyperopia, or the esotropia is due to this hyperopia, you're not going to see it when you're talking to the patient. So that's just something from my experience that, you know, it's good when the patient takes off their spectacles when they're talking to you. So whatever tropia that's being resolved or eliminated by your refractive error will now manifest. Okay, all right, let's get back to the slide. Okay, there was, to answer the person who asked that question, okay, very quickly, that when you are hyperopic, okay, now your accommodative system tries to mask this hyperopia, okay, so your lens start to increase convexity. So what happens? Your point of focus that falls behind the eye is now pulled onto the retina. Just like a latent hyperope, the patient will give you good visual acuities, okay, only because the lens has allowed the point focus to fall onto the retina, onto your fovea. Okay, so what makes a latent hyperope slightly different from an accommodative esotropia is the fact that one patient is tropic and the other isn't. But the accommodative system is active when the patient is looking at distance. Ideally, we shouldn't accommodate at distance, but in this case, the patient with uncorrected hyperopia is accommodating at distance to compensate for this refractive error. Okay, so let's talk about what the patient will look like when they come into your practice. Patients with an accommodative esotropia that's secondary to an uncorrected hyperopia, at distance they will have a tropia. Okay, so you will see it. Let's talk about the one right at the end, which is an accommodative esotropia that's due to high ACA ratio, which is, I call your convergence excess esotropia. Now, these patients don't normally have an esotropia when they're looking at distance. So when they're walking in, you're greeting the patient, you may not see the tropia, okay, until you get them to do some task at near. Okay, so when they start to look at near, the eye swings in. One of the eyes will turn in. Okay, so something is driving the eye to break fusion at near and not at distance. And what you'll find is when you're refracting these patients, they don't necessarily have hyperopia. Some I've seen that were even myopic, and some were even emmetropic. They had no refractive error. But as soon as they looked near, the eye swung in. So let's explain this. Why did the eye turn in at near? When you look at near, you accommodate. But accommodation and convergence is linked, right? We know that. Accommodation drives convergence. So by stimulating accommodation when you're looking at near, it causes a lot of it stimulates a lot of convergence, more than what your patient's base-in reserves can compensate for. Your base-in reserves are your reserves of fusion. It's your fusional ability to hold your eyes together. But because the convergence is so great, your fusion falls apart. Your reserves are not strong enough, so your eye swings in, and that's when fusion breaks. Okay, so just like we know what convergence excess is, where a non-strabismic case of convergence excess, where a patient has a larger esophoria at near than they do at distance. Okay, in this case, the esophoria is so great that it breaks down into a tropia. Okay, so then the middle type of accommodative esotropia, that's your mixed type. You will get a patient who has a bit of hyperopia, and when you correct the refractive error, you'll notice that when you remeasure the tropia after you refracted the patient, the angle has reduced. The esotropia has gotten much smaller, but it's not eliminated. It's still there. So then you think, okay, it's not purely due to the high hyperopia. So then you look at the patient at near, okay, and then what happens? The eye swings in much more. So how do we resolve this? We know that accommodation is driving too much of convergence. So let's try to relax that accommodation at near. So we lessen that overconvergence. And how do we relax accommodation at near? By giving the patient a plus lens at near. So you can prescribe a bifocal or a multifocal with a reading add at near. So it will reduce the convergence, the esotropia at near, and you've corrected the hyperopia, so that will sort out their binocularity at distance. So now you've created alignment. You've sorted out the patient's binocularity at both distance and near. Okay, so I don't want to talk about too much about management. I think that would be a whole nother presentation on its own regarding management, but that's more or less how we work with accommodative tropias. How to diagnose accommodative esotropia? Your cycloplegic refraction is how you would diagnose it. Okay, if a patient is purely accommodative, once you cycloplege your patient, you will notice that the esotropia will disappear totally. Okay, and I had a little patient who was 3 years old many years ago. More than 10 years ago, I remember this case very well because it was the child's birthday on that day, and they came in, the mother brought the child for an eye test. So I put in cycloplegic drops in the child's eyes, very large esotropia, and an hour later I go back to the waiting room and I was quite startled because the child had straight eyes. And you know, it was a good thing because it was the child's birthday, so at least for the day or for most of the hours of the day, the child had straight eyes. So that was a case of a pure accommodative esotropia that was resolved when you instilled cycloplegic agents to paralyze the accommodative system. Okay, so let's talk about how you would screen before you diagnose by doing a cycloplegic refraction. How would you screen whether the patient is an accommodative esotrope that's sitting in your chair? All right, the patient will fail the +2 test, meaning that let's say they gave you a VA of maybe 6.9 unaided. You put in a +2 in front of that eye and the VA is still 6.9. Okay, so we know the +2 should have blurred the patient by about 4 lines or more, but the visual acuity stayed the same. So all it told you was that the +2 relaxed the accommodation and it corrected that error, that amount of hyperopia. Right? That is why the patient gave you the same VA as they did when you didn't put in the +2 lens. All right. The next step, the next way to screen whether this patient could have an accommodative esotropia is, I said the esotropia is intermittent. Okay, sometimes it's there, sometimes it's not there. The accommodative system is active, so it is pulling, it is driving the convergence. So I've often seen that with patients that if the tropia is not always there, if it is there, the angle of the tropia is changing. Maybe sometimes the accommodation is pulling a bit more than other times. So I did notice this discrepancy regarding this type of esotropia. Okay, and I did mention previously, if the patient has binocularity and you're doing near tests, just look to see fusion breaks when you're doing NPC or taking a binocular VA. Okay, so any near binocular test, just observe the eyes to see if there's a break in fusion or if the eye is being pulled in. And patients with intermittent tropias, they have this sort of sensation. Okay, they feel this pulling sensation sometimes, and they will actually tell you. Okay, I had a student once while I was chatting to him in the corridor. He suddenly told me, "Did you see that?" And I said, "Yes, I just saw your eye get pulled in while we were chatting." And he felt that. He felt immediately that, you know, the sort of release, this break in fusion, and the eye swung in. Okay, and there's something in the bottom I have there, which is a partial accommodative esotropia. So since we're talking a lot about accommodative esotropia, just to note that partial accommodative esotropia is more common than a full accommodative esotropia, meaning that only a portion of that esotropia is due to an accommodative component. From most cases that I've seen in my 15 years at the binocular vision clinic, is most of the accommodative tropias I've seen were partial and not full accommodative tropias. So how do we know this? Okay, so when you fully correct a patient, the esotropia doesn't fully resolve. When you cycloplege the patient fully, you'll notice that, okay, the esotropia has disappeared slightly, but it's still there, which means part of that tropia is due to a non-accommodative component. Okay, and it is for this reason, when you refer a patient for strabismic surgery, an ophthalmologist will not operate until the patient has been wearing their refractive correction for 3 months. And I think recently I heard they prefer the patient to be wearing their spectacles for 6 months as a minimum before they consider going in and cutting, because they need to know for sure, is this angle of strabismus influenced in any way by the refractive error? Because they don't want to overcorrect the patient who goes in to correct an esotropia and the patient comes out as having an exotropia. Okay. Right, that was a mouthful. Let me just take a sip of water. Okay. Periodic intermittent tropia. Again, I want to talk about this before I continue talking about the clinical tests, because that's what our primary reason was, our flow of the day, or our flow with the patient in the chair. Okay, periodic intermittent tropia, as I mentioned, is we can predict when the tropia is going to manifest, whether its fusion is going to break at near or fusion is going to break at distance. Okay, so these are clinical pearls. That's something you should just, keep with you during practice, is if a patient is esotropic and it manifests at near, you need to think of convergence excess esotropia. Okay, and this is your high ACA ratio. And a high ACA means that the amount of convergence that's stimulated by the amount of accommodation is very high. So accommodation is driving too much of convergence, more than what is normal. Okay. The other case, if the patient is exotropic and it manifests at distance only, you need to think of a divergence excess exotropia. And this is linked to a high ACA ratio, meaning that the amount of convergence that's relaxed by relaxation of the accommodation when you look far is very high. So too much of convergence is relaxed, that the eye actually will swing out and deviate. Okay, so in both cases, these are high ACA ratio cases. The reverse doesn't happen, which is why I didn't put this here, because it will start to get confusing. It's just these two cases that are important. When I talk about the reverse, I mean that if your patient has an exotropia that only manifests at near, it doesn't mean that the patient has a high ACA ratio, because you converge at near. So if an exotropia is manifesting more at near, accommodation is not involved here. Accommodation is not driving the exotropia. Accommodation doesn't drive exotropia. It drives esotropia. So if you remember these two cases, then you know they are high ACA ratio cases. And why is it important to know that these are high ACA ratio cases? Is because you can now use lenses to manipulate and start to create situations where the patient will have more alignment throughout the day. The eyes will be aligned more of the day. They have better binocularity, and that's what we can do with lenses. Okay, so how would you determine an ACA ratio in a patient? Okay, so I find this test very valuable because more than any other test, I see the ACA, it links two worlds together, your accommodation world and your vergence world. So I actually emphasize this test more than any other test because it tells me so much about the patient that's in my consultation room. Okay, we're familiar with measuring the ACA ratio. All right, so forget about the Maddox swing. I doubt anyone has a Maddox swing in their practice, so forget about that. How do we measure an ACA when the patient is in the room? Normally what we would do if they didn't have a tropia, we would measure the foria. We'll put in maybe +1 lenses or -1 lenses and remeasure the foria. So the foria with the lenses and without the lenses, the difference will give you your AC. Okay, whether it's 4:1 or the difference is 5, then it's 5:1, all right? But how do we measure an ACA ratio with a tropic patient? Again, the principle is the same. When you measure the tropia, you write that value down there, then you put in -1 lenses and you remeasure that tropia. Okay, and you see if the magnitude changed. So the difference with the lenses and without the lenses is your AC. Okay, your ACA. All right. So that's just a simple way, a guide to measure the ACA ratio in your strabismic patient. All right, let's get back to the patient and our clinical tests. All right, now we need to ask ourselves, should we manipulate the patient's prescription to help them? Okay, we've refracted them, we've done 2 preliminary tests, we remeasured the foria, the tropia, we've checked the NPC. So now we're asking ourselves, should we manipulate the patient's prescription? What should we do to help the patient to increase the amount of time that the eyes are aligned throughout the day? All right, so here's some rules we can talk about, which is why I spoke about the ACA ratio. Okay, you can give more minus for an exotropia that is manifesting at distance mostly. Okay, so I'm talking about our divergence excess exotropia, this high ACA ratio type. So if your patient is myopic, you can give them over and above the refraction, you give them more minus, right? Maybe I'm being over ambitious when I had them -150, maybe up to 125. So this is trial and error. This is what you would do while the patient is in your chair. Okay, you put in -0.075s, you'll remeasure the tropia. Then maybe you'll try a -1. Then you'll try a -125. You're going to see which one is lessening that exotropia. And why will that exotropia lessen? Because you, with those minus lenses, you're stimulating accommodation and you're pulling the eyes together. All right, so I think before we really panic and say, why are we stimulating accommodation and distance? Trust me, it's fine. This is not traumatic for the patient, okay? Yes, you're stimulating accommodation, but it's realigning the eyes. They're going to have fusion. So you need to decide, what are you going to sacrifice more? Is it visual acuity, for comfort? What is our goal as optometrists? It's not only one goal. Our goal is not only to provide clear vision. Our goal is to provide clear, single, comfortable binocular vision. It's all of those things. So you need to weigh, as an optometrist, what are you going to do with this patient? Are you going to sacrifice a bit of the VA for the patient to have binocularity? Comfort is very important for the patient. Maybe the minus I've given is giving a bit of eye strain. So maybe I'll cut down a bit of the minus, okay? And maybe the binocularity will not be as great as it is with giving much more minus. So you find a compromise. So every case is different. That's my point. You need to decide for yourself what's the best way you're going to manage this case that's there in your practice. Okay. A second case, I would give more plus for a patient that's esotropic, where the esotropia is manifesting more at near. So after I've refracted the patient, I'll try to add just extra plus in front of the eyes, still getting them to read, take their VA, see how much of the VA is being reduced with this plus that I'm giving. Is the esotropia, the angle, getting smaller? Am I promoting binocularity? Am I promoting fusion by sacrificing the acuity? So how much of the VA line should I cut? Okay, so that's something also debatable. You will have to decide what will be best for your patient, how much of a compromise you should make. All right, so even though I say our goal is to provide single, clear, and comfortable vision, you can say, for this presentation, I spoke about asymptomatic patient. Yes, a patient with a strabismus will walk into your practice, they are seeing single, they are comfortable, they're not complaining of anything, okay, and they have clear vision, or you refracted them and you've given them that clear vision. So why should you interfere? Why should you manipulate your prescription? The reason is they have single, clear, monocular vision. That's what they have. They have single, clear, monocular vision. But we want to promote binocular vision. So which is why our goal of only providing clarity should move from just refractive correction, but manipulating the prescription to allow binocularity and comfort as well. Okay, I think I've driven that point too hard, and my apologies for that. Okay, assessing accommodation. Okay, we often forget that strabismic patients do accommodate, and specifically those alternating tropic patients. When they're fixating with their right eye, they will be accommodating if they're reading a book or doing work on their computer or working on their cell phone. When they're fixating with their left eye, the right eye goes esotropic and then they accommodate. So they are accommodating when they're focusing at near with the fixating eye. So it's important that we should assess accommodation in these patients. And then the patients with constant tropias, they tend to, if the accommodation is a binocular reflex, if you accommodate with your right eye, you accommodate with your left eye. Okay. But what I've noticed is patients who have a constant tropia and they have amblyopia, because of the suppression that's there, suppression is your precursor to amblyopia. It has to be there. So I noticed that that eye, when you assess the accommodative ability in that constant tropic eye, it's not as good as the fixating eye. And the reason I think is there isn't that fixational reflex there. That reflex to fixate is not there because that eye is constantly in a tropic position. So it's rarely used. It's never used actually until the patient only decides to take their hand and cover their good eye. Then the tropic eye will be used. So I think because it's not being used very often, the accommodation in that eye is not that great, not that active, which is why they say that patients who have amblyopia, it's not only a reduction in visual acuity, other visual functions are depressed in that eye. The motilities are not that great. They have staggered pursuits. The fixation mechanism is not that great. The accommodation is reduced. They have a reduced amplitude. So many visual functions are dampened in an amblyopic eye when you have a constant tropia. So we'd want to assess that in a patient because maybe the patient will eventually go for surgery and then the ophthalmologist will straighten that eye. But if you haven't addressed the accommodative problem in that eye will still not function optimally even though it's straight, even though it's been straightened. Okay. So what accommodative test we would do? I would check monocular amplitudes. Number 3, I would check your monocular facilities, especially for this age category of this presentation. School children are looking back and forth at the board. Facilities are very important. And MEM, you would assess the accommodative response. Can each eye respond as well as the other? Okay, how do you respond to an accommodative stimuli? Do you under-accommodate? Do you over-accommodate? Okay, I highlighted point 2 and point 4. Point 2, NRAs and PRAs, I personally found no much value in these tests regarding the accommodative system. These are binocular accommodative system. They actually tell me more about the Virgin system than the accommodative system. If I want to know something about the accommodative system, I would do monocular accommodative tests. BAF, your binocular accommodative facility, using the flippers in front of both eyes. Again, it doesn't add much value to me in a patient that has a constant and an alternating tropia, because they're only fixating with the one eye in any case. It's only when the patient has binocularity and they have an intermittent tropia, that's when I will want to do binocular facilities. I will check the patient's flexibility to relax and stimulate accommodation, because that's mimicking real life situations. When we walk around, we're looking near, we're looking far. When we're studying, when we're in presentations, when we're in lectures, we're looking back and forth. All right, so I highlighted that assessing the accommodative system is always possible, and there are tests that are indicated. Okay, we're coming close to the end of the presentation. We're assessing the sensory aspect of your strabismus in your patient. Your strabismus has a motor component and your sensory component. We can't do one without the other because one influences the other. So let us go straight into it and talk about this anti-diplopia mechanism. This anti-diplopia mechanism called suppression. Okay, and suppression, just to recall some theory, it's not a phenomenon, it's not an ocular phenomenon, it's a cortical phenomenon. It's a sensory adaptation of your brain. Okay, so once again, I mentioned previously, you send your patient for surgery, the eye gets straightened, but there's no guarantee that the suppression scotoma has vanished. Okay, a simple suppression test that you could do in your practice, or even when you go out on screening ventures, a simple red lens test with a pen light. Okay, so if you put a red lens in front of one eye, can you shine a pen light? If the patient is suppressing, they'll either just see a red light or they will see a pen light. Okay, so we could do this test if this is easiest and quickest for us. And what I like about this specific test is at any point during my examination, I can quickly do this test. Let's say the patient is now and has an intermittent tropia. I thought I spotted the eye turning in or turning out. Now I'm not sure. It looks aligned. I'm looking at my patient. I will quickly put a red lens in his trial frame, maybe while I'm refracting or while I'm doing some accommodation test, and I will quickly look, shine the light to see and ask the patient, do you see one light or do you see two lights? Do you see a pink light? Do you see the red light or just the white light? So it's a quick test to do at any point. Okay. Okay, for alternating tropias, they will alternate suppression. Hence, amblyopia does not develop in these patients. Okay, because as I said earlier, there's no competitive advantage between the eyes. Okay, constant tropias, they will definitely suppress that eye, and that's how amblyopia starts to progress. The size of the suppression scotoma will depend on the size of the strabismus. Okay, so if you have a large strabismus, you can expect the patient to have a large suppression scotoma in that eye. So why does size matter? The age-old question. Okay, so for optometrists, size matters. It does matter. Okay, and we're going to talk a little bit more about why should we care about the size of the patient's suppression scotoma. Okay, and a clue will be it has to do with their stereopsis. Okay, all right, we're going to come to that. So let's wrap up this slide. Foveal suppression, a patient who has a small tropia or a microtropia, they will have foveal suppression, meaning it's a very small suppression scotoma, and they will have peripheral fusion, which is actually good. So it's not that the entire visual field of that eye is suppressed. Okay, there is aspects of peripheral fusion that's visible. Okay, so this is more than or less than 10 prism diopters. Okay, the depth of suppression. Again, why do we care if we know the patient has suppression? Why do we want to know if it's a deep suppression, if it's a shallow suppression? Because we want to know how can we manipulate things so that we can promote binocularity. If it's a really deep suppression, we know we're not going to have much success to weaken that suppression scotoma. Okay, and the patient's stereopsis will be quite bad. All right, so the depth of suppression will determine the depth of amblyopia that the patient has. All right, so if you're doing amblyopia therapy, we're patching the eye, we know that we have to weaken the suppression scotoma. But if it's a very deep suppression scotoma, we know that we may not get significant improvement in the visual acuity lines. And I think I can just go on to, okay, we'll talk about the Worth-4 dot test. This is quite common. This is a test that we do a lot. Let's straight jump into the common errors with this Worth-4 dot test. Okay, changing the background color but not changing the interpretation. So I think some of you use the spectrum units, the programs where you can change the color of the background. You can have a white background or you can have a black background. Okay, but you need to remember the interpretation will change. If you have a black background, the eye with the red lens will see the red light. The eye with the green lens will see the green light. So if your patient only sees the red light, then you know the eye that has the green filter is being suppressed. But if you're using a white background, the interpretation is swapped around. Okay, the eye with the red filter will not see the red light. You will see the green dots that appear black. All right, so your interpretation is swapped around. So by convention, by standard rules, let's just use the black background and not the white background in a totally darkened room. Okay, so in a totally darkened room, it's easy to detect which eye is suppressing. To pick up the size of the suppression scotoma, if you have the Worth-4 dot torch, you can start from distance and you can come closer to the patient. You know when you're standing far from the patient, the torch is subtending a small angle at your eye, so the target is actually quite small. So if a patient has a larger suppression scotoma, they definitely, in one eye, they're definitely only going to see one color, either the red or the green. But as you come closer towards your patient, the torch is getting bigger, all right, to the point where the lights of the torch may fall outside the suppression scotoma, and then the patient sees all the lights. It doesn't mean the patient is not suppressing at near. It just means the size of your target is larger than the size of the suppression scotoma in that eye, right? Now, it's very difficult to suppress in a totally darkened room. So that is why it's very important for the room to be extremely dark. So if it's a deep suppression, the patient will still suppress in a very dark room. And when you swap to put the room lights on, or if you're using that spectrum unit that you can change to a white background, you immediately swap to the white background. Okay? Because it's easier to suppress under normal seeing conditions, because the room has a lot of visual cues. The patient can see the desk, they'll see your slit lamp, they will see chairs, they'll see a lot of things in the room while wearing red-green filters. Okay? Okay, so then it's easy to suppress, because suppression is a binocular phenomenon. They're seeing lots of things with both eyes in the room. But when it's totally dark, the only single target that is seen by two eyes is that white circle, that white dot. Okay, so it's difficult to suppress in a darkened room, and that's why you pick up a shallow suppression. If a patient then suddenly sees diplopia in a totally darkened room, or the room lights on, they only see one color. Okay, and our last test, stereopsis testing. Okay, what is its value? All right, so stereopsis is your highest level of binocular vision. Okay, so I often do this test when I'm dealing with anisometropic patients, and with my strabismic patients, I want to know, when they have a large suppression scotoma, I want to know, do they have any stereopsis? Okay, because stereopsis and depth perception is not the same thing. You only are able to perceive or experience stereopsis with both eyes. Depth perception, even with one eye, if you can close your one eye, you can still see things in 3D. You can still see depth, but you lose stereopsis when you close one eye. Okay, this is also very important if your patient is a long-distance driver and he has a strabismus. At night, all these monocular cues disappear when you're driving on a long, dark road. So he'll have to depend on stereopsis while he's driving. And stereopsis is only useful up to 500 meters in any case. Even outside of 500 meters, stereopsis falls apart to assist you to judge depth. So with these long-distance drivers, those that drive a lot at night, I would want them to have some level of stereopsis when you can't rely on monocular cues that disappear in the dark. Okay, if it's a large suppression scotoma, your stereopsis is inhibited. If it's a small foveal suppression, the patient will have, as I mentioned, they'll have peripheral fusion. So those patients have gross stereopsis, which is a good thing. If they can achieve some level of this, the highest level of binocular vision, I am happy. All right. So if you start to do therapy for this patient, you start to do amblyopia therapy, I would hope that as the suppression scotoma gets weaker, their stereopsis starts improving. So that's why my last point there is that doing a stereopsis testing is a good measuring tool that can determine if your amblyopia therapy or anti-suppression therapy is being successful. All right. If the stereoacuity is getting better, you know you're making progress with the patient. So don't toss your RAND.dot tests away. They do have a lot of value with your patient. Specifically about anisometropia, if I can just say one last thing about that. I use the stereopsis test as a guide because you're not sure how much of your patient's prescription to cut. I gave the example of a patient having -0.15 in one eye and 6 diopters in the other eye. You know you have to cut the prescription down because the patient is now going to see diplopia. They're going to see minification in one eye. There's abnormal magnification effect. So, and maybe contact lenses is not an option with the patient. So how would I know how much to cut? So I use my stereopsis test. As I start cutting down the prescription, I see if they can achieve some level of stereopsis. If they can, then I know, okay, maybe this is the most I can cut in my patient. Okay, so I use the stereopsis test as a guide as well. All right, so that was a mouthful, and that's a wrap, guys. Thank you very much. I will just take a sip of water before I get to your questions.
Thank you so much, Mr. Naicker. Colleagues, I've noted that some of you have sent through questions. Please be advised that I have noted all the questions and I've just emailed them to Mr. Naicker so that he can then go through the questions for us because there were quite a number of questions. So Mr. Naicker, if you can just quickly check your emails, you'll find that I've emailed the questions to you and you can then maybe start attending to the questions once you finish your sip of water.
Okay, All right, let me get to it. Okay, we have.
Have you found the questions?
I've just opened my email. I don't see.
Okay, maybe let me start reading them out for you.
Yes, yes.
Okay. The first question says, for intermittent strabismus, intermittent exo, is there any specific binocular balancing method if there is no manifestation of strabismus during refraction?
No, there's no preferred method. There are actually, I think, if I recall, there's 4 types of binocular balancing techniques. There's the HIC, the most common one we use. There's the prism dissociation one. But with all these binocular balancing procedures, we are dissociating the eyes. So I think one of the problems with dissociating the eyes is that we can then cause the strabismus to manifest by dissociating. So one good binocular balancing technique that I like is the bichrome, the one where you use the duochrome and you split it with the prism between the both eyes. I felt it to be a bit more sensitive, but with the specific intermittent exotropic case, I would say try different procedures and keep, as I mentioned earlier, look at the patient, just see if you are breaking the fusion at that point. Then try a different procedure. Okay, because as I said, different cases are different. Just see which one works for that patient that you have.
Okay, the next question says, do you believe traffic department must include depth perception in their qualification process to deal with strabismic patients?
Sure, that's an interesting one. Should they have a depth perception test?
Yes, I think that's basically what the question is about.
Should they have? Now, I think you mean like a stereopsis test or for a strabismic patient. Now, which one would we choose? Should it be, remember, most of our stereopsis tests are near tests, right, that we do in practice. These are near stereopsis tests. But there's only one distance test called the Howard-Dahlman apparatus. That one you can measure 3 meters, 4 meters. Okay, so you can measure the patient's stereopsis at different distances. All right, whereas the ones in your practice are the ones you hold in your hand. Okay, so I think if anyone has to measure depth perception, I would prefer the optometrist to do it than someone at the traffic department. But I think you're right, it does have value, but we must also note that stereopsis is only possible up to 500 meters. Beyond that, you can't even use stereopsis to judge depth perception. What test I would actually like to be included, since we're talking about the traffic department, is contrast sensitivity. I think that's also something valuable to be included in this battery of tests that they do at the traffic department. But that's another story for another day.
Okay, thank you. The next one is mainly a comment based on what you said earlier about visual field testing. And the comment says, Hansen 9000 visual field has a test option called Esterman 1 or 2 that is done binocularly to assess the binocular visual field for driving. So I think it was mainly with respect to the comment that you made about binocular visual field testing.
That would be good. I'm going to read up on that test, this binocular test, because this is, I would actually like optometrists to do this binocular type of testing. So I will get that name and I will read up, because so now it seems that Mr. Kobe, then you don't need to fund me from developing a binocular field test, because it seems there is one already out there.
Yeah. So the next one says, Cycloplegic refraction. Do you prescribe the total amount of plus lenses you got, or there is some power adjustment needed.
Okay, thank you for that question. It's a very good question. Do we give the full plus when we cycloplege an eye? Theory says you give the maximum plus. Okay, but what I found is that it reduces the patient's VA, where I'm afraid that this child, if I can say this child, will not want to wear their spectacles because they can see better without it. Because we know they accommodate at distance, they mask their refractive error, they get good visual acuities. So by fully correcting that refractive error, I feel that we may be inducing a blur at that point where they may not want to use their spectacle, all right? Even though theory says you have to give the full plus because it's the best way to relax that convergence. Okay, and giving the full plus means, and I say that it will induce blur, because when you cycloplege an eye, you paralyze the accommodative tonus that is always there. Even when you're asleep, you know, even when your eyes are closed, that tonus is always there. So by cyclopleging, you're paralyzing even that tonus, which is about 0.75 diopters. So I would, it depends on the patient. If it's a very young child, I would give the full plus. If it's a 2-year-old, 3-year-old, I will give the maximum plus. If the patient is older and they maybe a teenager or they're working, I wouldn't give the maximum plus because I can then communicate with this patient better and I can bring them in, I'll ask them questions, I can probe more, and then I'll decide maybe I can build up the plus with this patient or maybe I can cut it down a bit. But with a child who's, if I can say, nonverbal, I won't be so sure, but I will just give the full plus in that case.
Okay, thank you. The next one says, how do we check ACA ratio on a constant strab, e.g. a patient with a convergence excess?
Okay, constant strab, you'll neutralize the strabismus, okay? You can use your prism bar, okay, and you'll do your monarch test, okay, which means you're doing your alternating, and you'll neutralize until there's no movement. That's the measurement of your total deviation. Then you'll put in minus lenses in front of each eye, and you'll remeasure that tropia. And you'll see if there's a difference between the magnitude before and after you've put the lenses. That will be your AC.
Okay, thank you. The next one says, which one is your preferred method, physiological or calculated? And I would suppose they're referring to the ACA ratio here.
That's a tricky one. I prefer the calculated method. The reason that the grade, because even though the calculated may take us a bit of time, because we now got the patient in the chair, we're doing some calculation there, the gradient is quicker. But one of the shortcomings with the gradient is the fact that the patient has a lag of accommodation. If I say I'm measuring the ACA ratio, I'm putting +1s in front of the eye, we say we're relaxing the accommodation by 1 diopter. But do you agree you're not really relaxing the accommodation by 1 diopter? Because a patient is not fully accommodating for a specific target at a distance. They under accommodate, they have a lag. So if you want to know which is more reliable, I will go with the calculated method. But which one is more quicker? I would say your gradient method. And your gradient has some shortcomings to it. And one being your lag of accommodation, because you never fully accommodate for a target.
Okay, the next one is more a comment. It says, I had a patient that refused to wear full RX due to exotropia. I was happy with reduced plus for alignment, otherwise would not wear specs at all. Do you have anything to say to that comment?
Is the comment the patient was happy with their glasses?
Yes, was happy with a reduced, let me just read it again, was happy with reduced plus for alignment.
Yes, that's right. That will make sense because we know plus lenses stimulate divergence. It will aggravate the problem. So if I cut down the patient's, if this is a hyperopic patient, I'll cut down their plus prescription, and maybe it will help with alignment a bit more. So yes, definitely that's correct. It makes sense that a hyperopic unfortunately you get those cases. You would want a patient with an exotropia to be myopic, all right, because the minus lens will stimulate a bit of convergence. It will pull the eyes in, but you do get patients who have an exo plus they have a plus prescription. So yes, it's good to reduce that prescription, the plus prescription.
Okay, then the next one says, up to what age is therapy successful?
Oh, that's one question that's always debatable and always asked. Okay, it depends what therapy you're talking about, right? Are you talking about amblyopia therapy? Okay, let's assume that is the question about amblyopia therapy. I think it all depends on the patient's motivation. I've heard of cases where a 40-year-old had improved his visual acuity by one line for doing therapy for a few years. So you have to be very compliant, meaning doing therapy for a few years, he managed to improve his visual acuity, even though the science says that you beyond the critical period, your visual, your sensory system has already been developed, but it shows that even in your 40s, you can manipulate things because your visual deprivation happens in your brain, all right, in your cortical areas. So if you stimulating those cells in your brain to become active, I think it makes sense that it's possible later in life that you can have success with amblyopia, if that's a therapy you're talking about. Also, anti-suppression therapy will go hand in hand with amblyopia therapy. So, because if you're weakening your suppression scotoma, your depth of suppression, you then weaken that deep amblyopia there as well. All right. So I think at any age, but we know that you have greater success when the patient is younger as opposed to being older.
Okay. The next one says, at what age is surgery recommended?
Sorry, at what age is surgery?
Yeah.
Recommended.
Yes.
Okay, that will depend on what the purpose of the surgery is for. If it's for cosmetic purposes, then we know at any age, okay, a patient can go for surgery. If it's to help with amblyopia, if it's to help with the eye from becoming amblyopic, if it's to help with strabismus, then I would say the earlier the better. That would be my answer. The earlier the better the patient goes for surgery.
Okay. Next one, which is very similar to that, says, at what stage will the patient be referred to surgery? I think you have already covered that. And the next one says, what if the patient has an esotropia, but the RX is myopic? And if patient has an exotrope, but RX is hyperopic, won't the strab get worse in both cases? How do we approach this?
Okay, that is true. It can cause the strabismus to get worse because minus lenses actually works against a patient that has an esotropia because it's going to stimulate convergence. But just remember that your accommodative system plays a big role in this. Okay, you have to look at the accommodator. How much is your accommodations driving your convergence system? Then you'll know how much lenses are influencing the strab. If you have a low ACA ratio, for example, like convergence insufficiency, very low ACA ratio, they have a larger exo at near. Okay, so if they have a hyperopic script, yes, we know hyperopia is going to stimulate divergence. It's not going to help this patient with convergence insufficiency or that breaks down into an exo very much. But if it's a low ACA, we know then your lenses may not influence the deviation too much. It all depends on accommodation, how it influences your virgin system. Once you know that, you got something to work with. Okay. You could have a patient that has bilateral cataracts that were removed, and this patient has IOLs. And then I will tell you that your lenses will make no influence, whether you're myopic or hyperopic, because the patient has no accommodation to drive virgins. So your lenses will have no influence.
Okay, I have one last question. If a patient has esotropia and myopia, it's exactly the same question. My apologies. I think there's two people who just asked the same question. And I think maybe the other thing that I see that the people are asking for on the chat is asking for the presentations. Can I send them the presentation?
Look, they can have the presentation to help them if you feel it will be valuable.
All right. Okay. All right. Colleagues, I'm checking on the chats here. I do not see any more questions. And I think looking at the time, we've exhausted our 2 hours. And at this stage, I would like to thank Mr. Nashua Naicker so much for taking time out of your busy schedule and preparing this wonderful lecture for us. I see that a lot of people are sending messages saying that it was very informative and they really appreciate. I've actually been seeing one that I'm not too sure if colleagues would be happy with, which said that the 2 hours was not enough. So
yes, I needed 10 hours.
So thank you so much. I think we appreciate the feedback. And Mr. Nashua Naicker, any last words from your side?
Yes, just to thank everyone for your attention, for your questions. I'm sure it's difficult during lockdown, especially those at home and you have family that you have to attend to. So I've disturbed you for 2 hours, but I hope it was valuable.
Okay. Thank you so much, colleagues. It was definitely valuable, and we really appreciate your time, Mr. Nashua Naicker. And I also would like to thank you, the colleagues, for taking time out to come and attend this. I know 2 hours in some instances might be a lot, but I think this, you would agree with me that it was quite valuable, and it's going to assist with how we examine our patients going further. Thank you so much. Colleagues, the webinar will now be closed. Thank you.